have the pleasure of introducing our speakers. Chase Barnes is the Harm Reduction Program Manager for the Kentucky Department of Public Health. In this role, he is responsible for the overall management of the harm reduction program, serves as a lead advocate for public health harm reduction initiatives, and provides guidance and technical assistance to local health departments, syringe service programs, health reduction groups, and other agencies and organizations. Chase received his Bachelor of Science in Public Health degree from Eastern Kentucky University and completed his Master of Public Health degree at EKU in May of 2022. Jana Collins serves as the project director for the Kentucky Income Reinvestment Program, or KIRP, which is tasked with reinvesting program income generated by Kentucky's AIDS Drug Assistance Program into HIV initiatives throughout the Commonwealth of Kentucky. Jana has previously served as the research program manager for the HIV programs at the Ryan White HIV/AIDS program, funded Bluegrass Care Clinic and the University of Kentucky, where she had worked in various capacities since 2002. Jana serves as a fiscal, administrative, and technical assistant consultant for the Health Resource Services Administration HIV/AIDS Bureau, participating in comprehensive and technical assistance sites for the Ryan White HIV/AIDS program recipients since 2008, and is a consultant for the HIV's Fiscal Health Professional Services. So I'd like to welcome our speakers today. I'm going to turn it over to Chase.
Hi, everyone. Thanks so much for having me. So first, just to go through that neither Jana or I have any relevant financial relationships to disclose during the past 24 months. Our learning objectives today are to describe the evolving opioid, HIV, and hepatitis C epidemics, describing the key principles of harm reduction and the role of syringe service programs in reaching highly vulnerable populations, and explaining successes, challenges, and lessons learned from harm reduction syringe service programs in poor Kentucky communities. So first, I just want to provide you all with a very brief update of our current overdose landscape for the United States, and then more specifically for Kentucky. So this is a national map by state breakdown of drug overdose mortality by state in 1999. Just want you to kind of reference that on the west, the western portion of the United States is where the most drug overdose mortalities were at that point of time. And also keep in mind that the highest range of this is age-adjusted death rate of 12 to 15. Was the highest range at that point in 1999. And then in comparison to 2020, so you can see definitely that shift from the West Coast now to the Appalachian area of the United States, and more specifically, how those age-adjusted death rate ranges have increased to where there is no state under 10.3, and the highest rate is 67.18 through 81.4. In addition, West Virginia leads the nation with the most drug overdose deaths per capita in 2020, and that's with 81.4 per 100,000 population. Kentucky is second in the U.S. for drug overdose deaths per capita with 49.2 per 100,000. So with our recent data that we have for Kentucky by county breakdown of age-adjusted rates, so you can see the number of deaths per 100,000. So the purple counties are 60 or higher. And then also the red line that you're seeing indicates the Appalachian counties within the state as well. And this is from research data from Kiprick. Now to just focus on the top 5 counties in Kentucky that have the highest rate of drug overdose deaths in 2021. So our first of Estill County with 147.89, with the number of actual drug overdose of 22. Second, Gallatin County with 145.89 rate of overdose deaths with 12 actual overdose deaths. Third, Perry County with 141.81 with 35 deaths. Round County in fourth with a rate of 130.82 with 27 deaths. And then number 5 coming in with Knott County for 122.67 with 16 deaths. And this is from the Office of Drug Control Policy. Next, to also break this down a little bit more for top 5 counties that have the highest number of drug overdoses that involve fentanyl. So first, I want to focus on the right-hand side of the page that does the county breakdown with the heat map. So you can see that the counties in purple again are the highest rated, which reflect over here on the left side with that actual drug overdose death count that involves fentanyl. So with, of course, Jefferson County having 477 deaths, Fayette County with 135, Kenton County with 73, Madison County with 69, and Boyd County with 36. Next, to focus on the same thing, top 5 counties and statewide, but these are the highest number of drug overdoses involving methamphetamine in 2021. So with this, Jefferson County again, 250 deaths as number 1, Fayette County with 53, Madison County with 46, Boyd County with 32, and Kenton County with 24. This is a breakdown of the substances that were found in drug overdose toxicology testings. So these are the top listing of substances that were identified through those toxicology reports. Of course, fentanyl and amphetamines are the majority of the frequency for 2021. And this is also coming from Office of Drug Control Policy. Now I'm going to pass it over to Jana.
Thank you, Chase. So now we're going to kind of shift the discussion to the infectious disease complications that come through injection drug use. And I promise we're going to kind of marry this together as we go through the slides. So I know this study is getting old at this point. We're about 9 years past the original study that kind of kicked a lot of this off. But I think it's really important to still mention it because it did kind of change how the United States as a whole was looking at infectious disease, specifically as it relates to injection drug use. So back in November 2014 through October 2015, there was a place in Indiana called Scott County, Indiana, that many of you all are probably aware of this study, but it's a small town. It's similar in county size to Perry County, Kentucky. They have approximately 24,000 people that live in Scott County, and typically they had about 5 people that were diagnosed with HIV per year. During this particular time period, they had 181 people that were diagnosed with HIV. And the issue was that HIV had gotten into the injection drug use community through sharing needles, through sexual transmission, and had kind of, just really spread very rapidly within their community. And so as this happened, I was at the Bluegrass Care Clinic at the time, and we were serving HIV patients. And so I remember this, there were a lot of calls with HRSA and CDC looking at actually some connections between counties in Kentucky and the Scott County structure in Indiana, and making sure that if there were people that moved to Kentucky that we got them into care. So it was quite a crisis at the time while it was happening. But after the fact, the CDC did a study to assess other counties in the United States that had similar factors that Scott County had that they felt led to this rapid increase of HIV and hepatitis C. And so they looked at 6 specific domains when they were going through this study: drug overdose mortality, access to prescription opioids, access to care, drug-related criminal activity, prevalence of injection drug use, and sociodemographic characteristics associated with those geographic areas that were associated with higher injection drug use prevalence. And through that study, they identified 220 counties that they felt had similar issues to Scott County and may be at risk for an HIV hepatitis C outbreak. And Kentucky had 54 of those. And so you see a map, it's going away. We're moving to more current maps, but there are maps out there that have green counties that identify several, 54 counties specifically in Kentucky that had those risk factors, that perfect storm that could make an HIV hepatitis C outbreak probable within those areas. So, when you're looking at acquiring HIV, and we'll talk about hepatitis C separately, but blood transfusion is the highest method of acquiring HIV, and science and progresses in our country as a whole has reduced that in terms of testing blood and ensuring that blood transfusions are safer than they were at the beginning of the HIV epidemic. Receptive anal intercourse is the second highest transmission act that would put a person at risk for HIV, and third is sharing during injection drug use. And then it kind of goes from there. And so if you look at Kentucky data, you see over the last several years an increasing percentage of new patients that are diagnosed with HIV that identify injection drug use as their risk factor for acquiring HIV. In Kentucky, you see that since 2016 and 2020, it was about 13% of the diagnosis in Kentucky, and fast forward to 21-22, and it's 19% of the diagnosis in Kentucky of people with HIV. Northern Kentucky, as many of you know, had an outbreak between 2016 and 2020, so they had a significant increase of people diagnosed with HIV during that time period that had injection drug use as their primary risk factor. That has since decreased, but you see that 20% is still high compared to the numbers in Kentucky. Over the past 2 years, we've seen an increase in Louisville of people being diagnosed with injection drug use as their primary risk factor. We haven't seen that increase like we have in the other areas in the Bluegrass Developmental District, but that doesn't mean that it's not coming, and it's not something that we have to be looking for and testing for. Next slide, please. So, the important thing about this is the transmission risk of HIV when people do and do not know they're HIV positive. When a person is HIV positive, we'll kind of go through a very rudimentary clinical assessment of what happens, because I'm not a clinician, but many of the cases that of new diagnosis are due to people that do not know their HIV virus and are transmitting the virus to other people. Some of these data points are really scary. 1 in 7 people with HIV don't know that they have HIV. 1 in 2 people with HIV had the virus at least 3 years before they were diagnosed, and 1 in 4 people have the virus at least 7 years before they're diagnosed. And we'll talk about the significance of that as we go through this discussion. But the important point here is that 8 of 10 in new infections come from people who are not in HIV care. 15% of people with HIV didn't know they had HIV care, and they resulted in 38% of new transmission. An additional 23% knew they had HIV infection, weren't in care, and that resulted in 43% of the HIV transmissions in 2016. So the take-home lesson here is really helping people identify their HIV diagnosis and getting them into treatment. And that's really where our program is, which we'll kind of talk about more later, how we're partnering to make that a reality. So I always want to include this slide. Again, I'm not a clinician, but I think it's an important picture of HIV and the impact in a person's body when HIV is introduced into their body. So before HIV infection, those purple ovals represent the person's immune system. Those are their CD4 cells and their ability to fight off other infections. At acute HIV infection, the virus replicates very rapidly. And during that time period, a person may not know that they're HIV positive, but they're also very infectious during that time period. So if they're continuing to engage in risky behavior, they're likely transmitting the virus to other people that are coming in contact with. With chronic infection, once after the first few months of HIV infection in the body, the replication decreases a little. But as the person goes through their life, if they continue to be, obviously they continue to be HIV positive, but if they're not on medication, the virus continues to replicate and it continues to wreak havoc on their immune system. So you see the red circles, which represents the HIV infection, continuing to replicate and continuing to have a presence in that person's body. And you see the purple ovals going away. And the purple ovals going away means that their immune system is being attacked and they don't have the ability to fight off regular infections that people who are not immune compromised or do not have HIV can normally fight off. And so, if our goal is when a person is in acute HIV infection, if we can get them tested and get them identified as HIV positive, we can get them into HIV treatment, get their virus under control, get the red dots in a smaller portion within their body, make them untransmittable so that if they are engaging in risky behaviors, they're not likely to transmit their virus, and save their immune system, to help that person live a normal and healthy life. And so it's really important that for a person who's HIV positive, that they get engaged in care early on in their infection. Next slide, please. So when you look at Kentucky data, as you would probably suspect, most of the HIV positive cases are in Louisville, are in the central Kentucky area, and are in the northern Kentucky area. But this, the image to the right is the one that I really wanted to focus on, and that's the concurrent diagnosis. A person is considered a concurrent diagnosis when they're diagnosed with HIV and AIDS within 30 days of each other. So they have an HIV test, if they're HIV positive, and because of their impact on their immune system or other opportunistic infections, they're diagnosed with AIDS at the same time. That typically means that a person has had HIV for 7 to 10 years before their diagnosis. So it has already gone through the replication of the virus and the beat against the immune system, and they have already reached AIDS without even knowing that they had HIV. And if you look at the Kentucky data, our southeastern part of the state, they have a rate of 35% of new diagnoses are concurrently diagnosed. So they're diagnosed with HIV and AIDS at the same time. So even though they represent a smaller number of HIV tests within our state, this really just demonstrates, number one, looking at Chase's slides, the risk factors that exist in that area of our state and the Appalachian counties in our state, but also just the lack of testing, the lack of information, the lack of knowledge of risk, and knowing their HIV status and getting into care. And so if you look at the counties that were identified in the CDC as vulnerable counties, you see the same counties. And so that's really a lot of our work. When you look at the work that we've been doing, we started there because we really wanted to focus on those counties that were vulnerable for a variety of factors to an HIV outbreak. Next slide, please. So just to talk a little bit about hepatitis C. Hepatitis C transmission, injection drug use is currently the most common mode of hepatitis C transmission in the US. The second highest is through a child that's born to a hepatitis C infected mother. There are a variety of other ways that hepatitis C can be spread, but for the most part, most of the new cases are through injection drug use and through perinatal transmission. Next slide, please. And if you look at Kentucky's numbers, we don't fare well. Kentucky is ranked 7th in the nation in acute hepatitis C rates. That's actually lower. In the past, we've been up to number 2. So we have come down, or maybe other states have gotten better than us, but we are 7th in the nation in terms of acute hepatitis C infection. Next slide, please. And then if you look at the rates by population, Kentucky still remains among the highest states in the United States for acute hepatitis C infection. And a lot of this is tied back to the injection drug use that Chase started us off on and that we've talked about that is rampant through many of our communities throughout the state. I will turn it back over to Chase.
Thank you, Jana. So now I would just like to provide just a brief high-level overview of what harm reduction is, as well as syringe service programs and what they do. What is harm reduction? Harm reduction, in definition, is a set of ideas that's aimed at reducing negative consequences that are associated with substance misuse for individuals, their families, and communities by meeting people where they are. Harm reduction practices are used by everybody every day. Again, harm reduction focuses on reducing the negative side effects rather than stopping the behavior entirely. Some examples of harm reduction in practice include syringe access, overdose prevention, safer drug use, fentanyl testing strips, medication for opioid use disorder, housing first models, and supervised consumption sites. to dive a little deeper into syringe service programs. A syringe service program is a community-based program that provides key pathway to services to prevent drug use, HIV, and viral hepatitis. Some context on the history of syringe service programs in Kentucky. In 2015, Kentucky Senate Bill 192 granted approval for local health departments to operate substance abuse treatment outreach programs, which then allows participants to exchange hypodermic needles and syringes. It's important to note that the items exchanged at these programs shall not be deemed drug paraphernalia while located at the program itself. And to follow up from that, Kentucky Department for Public Health published guidelines for local health departments implementing harm reduction and syringe service programs. Some context of the steps that a health department would need to go through in order to operate a syringe service program. So first, you would have to have the approval of the local Board of Health for the health department, then followed by if they're located in the city limits, then they would have to have city officials approve, and then regardless, they would have to have their county officials approve as well. So the timeline of the steps of approval depend on the community itself and who would be involved. Example of syringe service program services that are to offer, free sterile needles and syringes and their safe disposal of them as well, referral to mental health services, as well as substance use disorder treatment, including medication-assisted treatment, HIV and hepatitis testing and linkage to treatment if applicable, overdose treatment and education, including naloxone distribution, hepatitis A and B vaccinations, linkage to other community resources that are available, including transportation, employment, housing, food, and others, as well as other tools to prevent HIV and hepatitis C, including counseling and condoms. This is a new updated map of the syringe service program sites that are across the state. So you'll notice that there's a lot of different groupings of colors of counties. So those are designated district health departments that cover multiple jurisdictions. And then the non-colored counties are independent individual health departments for a county. So as you can see, the red stars that are placed in the counties, that indicates that if the county has an operational SSP. So to date, we have 83 operating syringe service program sites in 64 counties. And I will add that we are leading the nation in the total number of operating syringe service programs in a state. This is a very high level overview of syringe service program cost analysis. So in Kentucky, the analysis of a participant cost per year is $125 to $1,000, and comparative to the cost for an HCV cure per infection of $20,000, and then also in comparison to HIV treatment of a range from $21,600 to $54,000, and then also to an additional. There will be some links that are sent out for additional research for this that goes in more depth into the hepatitis C patient cost analysis without a cure of over $200,000. And for now, I'll pass it back over to Jana.
Thank you, Chase. So I wanted to talk about the CURT program and our partnership with the Kentucky Department for Public Health. So the vision of our program, we started in 2018, and the goal of this program is really to enhance health, safety, and well-being of all people in the Commonwealth of Kentucky, really by addressing these high-risk behaviors, providing education, and providing access to medical care for people living with HIV. The HIV focus from our funding, or from our program, comes from our funding sources. We are primarily funded by income that is generated by the Kentucky AIDS Drug Assistance Program. Our focus started and highly remains focused on people living with HIV, but we have added additional funding sources, which has allowed us to expand into other areas that we know exist throughout our state through our discussion about hepatitis C transmission, syphilis, and other infections that are caused by these risk factors. Our mission is to provide comprehensive education and screening to those that are at highest risk. When we identify people that are HIV positive or hepatitis C positive, we want to link them to additional services to seek medical care, to seek supportive services. And then also we partner with the Kentucky AIDS Education Training Center to provide education to current healthcare providers to address substance use disorder and mental health issues that really impact HIV and hepatitis C treatment. So our program is a memorandum of understanding agreement between the Kentucky Department for Public Health and the University of Kentucky. The University of Kentucky has served as the contract pharmacy for the Kentucky AIDS Drug Assistance Program for 10 to 15 years. I'm not sure the exact date on that, but the Kentucky Department of Public Health partners with the UK retail pharmacy to provide medication for people living with HIV across the state. And that program, which has existed long before I joined in 2002, has gone through a lot of changes. When I first started, we had a waiting list for the Kentucky AIDS Drug Assistance Program. And if a person was diagnosed with HIV, they may have to wait a couple months before they had access to HIV medications. But the Affordable Care Act and Medicaid expansion really changed the complexion of HIV treatment in our state and what our KDAP program was able to do for patients living with HIV. The Part B program started purchasing insurance for people who were not eligible for Medicaid. With Medicaid expansion, we had a large percentage of our people living with HIV that were now eligible for Medicaid. And so KDAP moved from being a program that was kind of self-sustaining, required a waiting list, to a program that generated income through the 340B pharmacy program. And so because of Ryan White guidelines, those income dollars have to be reinvested back into HIV initiatives across the state. So our program, in partnership with the Kentucky Department for Public Health, helps invest those funds in areas across the state, including the Target 4 program, which I'll be talking about today. So the Target 4 project, if you have been around the CURT program since we started, we went through a rebrand last year. We started as two initiatives, one called the Harm Reduction Initiative and another program called Kentucky Finding Cases. Both were focused on HIV testing within at-risk communities. The Harm Reduction Initiative was particularly focused on partnering with local health departments through the Syringe Service Program partnership. And Kentucky Finding Cases was focused on outreach efforts in certain areas of the state. And so in 2020, we started talking about merging those two programs and really becoming more of a model that served the entire state and focused on both, focused on the Syringe Service programs and the outreach needs of all of our communities. So the Target 4 project is focused in 4 areas. That's where the 4 comes from: targeted HIV testing, referral services, and that is really taking a status neutral approach. If a person is HIV positive, we're referring them to HIV medical care and supportive services. But if they're negative, we're providing supplies and education that they need to remain negative. We're referring them to PrEP and other services that can help maintain their health and keep them from becoming HIV positive. If they're hepatitis C positive, we're referring them to additional testing, confirmatory testing, and then hepatitis C care. So the referral kind of takes multiple layers depending on the needs of our patients. Obviously, linkage to HIV care is a prominent part of our program because of our Ryan White funding. And then just general health education and risk reduction. Ensuring that our participants that we come in contact with through the Syringe Service Program or through outreach activities has the knowledge that they need to make safe decisions for themselves, the supplies that they need to keep themselves safe, and to be an active member of our community. Next slide, please. So our focus is on targeted testing, and I do this slide set with every employee that we add to our program. Our goal is not sheer volume of tests. I'm not interested in sending staff out to test in places where they're not going to find HIV. Our goal is to use our resources, be it manpower, be it supplies, to really target certain areas of our community that are at high risk. So that's looking at the CDC populations that bear a disproportionately high percentage of people living with HIV. That's men that have sex with men. That's people who inject drugs. That's our African American communities, our Latinx communities, and ensuring that we're providing appropriate testing in those populations that do bear a higher burden of HIV throughout our state and throughout our country. I tell our staff we want to be in the right places at the right time. If we are partnering with an agency and we continue not to find positive cases, it doesn't mean we abandon that agency. It means that we find a better time to be there. Maybe we don't need to be there during the week from 10 a.m. to noon. Maybe we need to be there on the weekend, or maybe we need to be there in the evening if they offer evening services. So it's looking at the times to interact with people who have a high risk for being HIV positive or hepatitis C positive, getting them tested, providing them information, and getting them linked to services. Our success and outcomes is based on positivity rate. So that's what we look at month in and month out, is working with our staff to increase the positivity rate of those we test. Our goal is a high prevalence rate of 2%. We haven't made it there yet, sustained that through our entire program. But for instance, when the Jefferson County outbreak was starting to occur, we were at 3% positivity or 5% positivity in Jefferson County, because we were finding a lot of people that were HIV positive through testing efforts there. In rural areas, that percentage tends to be lower because it's harder to find people that are at risk, and you have to do a lot of work to get into the community. Not that you don't have to do a lot of work to get into the community in Jefferson County. Everybody's doing hard work to get into the community, but it's just the volume of people that present for testing are very different between our rural and urban sites. Low prevalence is 0.1%. For every 10,000 people you test, only 10 would be positive. We want to be in the 200 number, that people that we're testing are at high risk, do need that information, need the supplies to keep themselves safe, and then, return to their daily activities. I will say one thing that when we first started, about 60% of the people we tested had never been tested for HIV before, which is great. We're finding people that are at risk for HIV that need to be tested. Now we're moving towards 40 and 50% of the people that we test have never been tested before. And I tell my staff, both are good. We need to find people that have never been tested before that continue to be at risk and get them tested and let them know our status. But there's also a population that continues to be at risk for HIV, even though they've been tested once. And so we need to make those opportunities and that frequency available so that people can come get tested, so that they know their status. So they're not finding out 7 and 10 years after they've contracted HIV that they're HIV positive, when their immune system has really taken a hit. So, we're seeing that number change a little bit, but I think, it speaks to the need of having available testing in those communities that really didn't have that before, and having the opportunity for people that continue to be at risk to have those opportunities to be tested at some level of frequency. Next slide, please. So Chase already showed this slide, but what I kind of wanted to reiterate with this program is that we didn't want to recreate the wheel. The local health departments had done an incredible job, and Chase kind of briefly talked through the approvals that had to happen, but that is no small feat. If you've worked in a county and you have gone through that approval process to get a syringe service program, that is hours and months and years of work to build grassroots advocacy and to get those approved in communities. And so that foundation had been laid. The local health departments had done an incredible job of getting these programs up and running. But the discussion with us when we were first starting is that the manpower was the issue. At the local health department level, having manpower to provide a full range of services was difficult. Health departments integrated these services with the staff that they had. And so you had people that had other jobs that were working the syringe service program and trying to provide this needed service in our community. And so our first discussions was, how can we partner with you? How can we slow the pace down? How can we ensure that people that are coming to the syringe exchange are getting not only the supplies they need, but getting the education they need, being offered HIV and hepatitis C testing, and receiving that education. If they have wounds that we need to preliminary look at and kind of tell them not only how to maybe inject safer, but also how to get medical care for those wounds. How can we do that and build rapport with patients? And so that's really how we started. We started because we wanted to be a partner. We wanted to partner with the local health departments and provide services that really the capacity hadn't been there fully. When we first started, about less than 2% of the people that had used the syringe service program had been tested for HIV. And, you know, the commissioner at the time really saw that as a missed opportunity, that we have people that are interacting with our health system through the local health department services. And if we could embed staff, manpower, supplies into those counties and increase HIV and hepatitis C testing, that would help us really address some of these vulnerable county issues and prevent transmission of HIV and hepatitis C through our injection drug use community. And so that's, you know, that's where we started. We worked with the health departments to interview staff locally. We didn't want to hire a bunch of people from Lexington and Louisville and plop them all over the state because they wouldn't be effective. We wanted to hire people that lived within the counties within which they were going to work. So they had partnerships, they had experience within the community, they understood the culture and the parts of the community that may be at most risk, and had that internal buy-in, you know, just by being knowledgeable of the community and being able to work with the staff there. So we worked with the local health departments to hire staff that made sense for their program, that would be a good partner within their local health department and a partner within their community. Next slide, please. So our program is set up with 13 regions across the state. One starts on the far western side, 13 is on the far eastern side. And so we have team leads that work in each of those regions and oversee the efforts within those regions. When we initially started, our services were really focused on specific counties. We had staff, or we still have staff, embedded in specific health departments, and their focus was really on that county. But as we made this transition from the harm reduction initiative to the Target 4 program, we've taken a much more regional approach. Our goal is to provide services in every county, whether they have a syringe service program or not, the need is there. And so, you know, in the counties, like Chase said, the 64 counties that have syringe service programs, we want to partner with those counties and provide HIV testing at some level of frequency, monthly, quarterly, at some places weekly, to make sure that the participants there can be tested for HIV. But then outside of that, we want to provide outreach opportunities with collaborating agencies, with certain areas in the community where we know that there is a high risk for HIV transmission. Next slide, please. So our staff provides screening and education and linkage to care for people that are at highest risk for HIV and hepatitis C. They distribute prevention supplies, education materials, and we are able to incentivize HIV testing as part of our program. And again, you know, our goal is to connect our participants to programs throughout the community. So HIV treatment, PrEP, hepatitis C medical care, mental health services, substance abuse counseling, all of those community level services we want to connect our participants to if it's a need that they have. So just to kind of give you an idea of our data. So in 2022, about 45% of the participants that use the syringe service program, and this is looking specifically at the sites that use the KDPH REDCap tool. We have just moved to an annual summary report, so I'm getting ready to get the data for all the syringe service programs, which I'm so excited about. But looking at the KDPH REDCap tool, about 45% of our participants were tested for HIV during the last year. Our goal is to, we don't test people more frequently than quarterly because that's not, you know, the medical practice is quarterly testing if a person's at risk, but our goal is annually. At least once a year, we want all of our participants to be tested. Our goal is 75%. We're still striving towards that, but you see a significant increase from when we started, when about 2% of participants had been tested for HIV at that time. We're up to 45%. I wanted to kind of point this out. These next two slides are ancillary information that we get from the tool, but I think it's really important. It's something that we use to educate our team. This number has changed. Back in 2021, when we looked at this number, we saw that opioids were on a decline and meth was continued on its rise. And you're seeing these numbers. This is looking specifically at our new participants, and they identify the drugs that they inject or use at our programs. And so we've seen a steady increase of meth over the years. Opioid dipped a little bit in 2021, but it continues its increase in 2022. And really, we just use that information in terms of education. I probably don't have to tell you all, but the injection of meth is different than the injection of opioids. in terms of how many times a person may inject, the risk factors that person may be at risk at because of their meth use versus opioid use. And so that really requires different education, different supplies, different information given to those participants to make sure that they are safe in other activities that go along with their drug use. And so, it's really, that piece of information is important so that we're giving that participant information where they are and educating them based on their own personal risk and not just our risk as a whole community. Next slide, please. I also like to present this slide just to kind of show you, oftentimes, I think we're looking just at the tip of the iceberg, and there's a whole lot under here that we're missing and continuing to strive for. In the data, there's an estimate that about 1.06% of the population injects drugs. When you look at Appalachia, that percentage rises to 2.4%. About 2.4% of the Appalachian counties are considered to have injection drug use as a risk factor. What we did is we looked at our participants and the client in which they live, independent of where they access services, just in terms of where they live. And if you look at Powell County, the population of people that live over that are over 14 years of age is 9,000. About 400 people in Powell County utilize the syringe service program, which is up to 4% of the population of Powell County being an injection drug user that uses the syringe service program. Other data suggests that only about 50% of the people who inject drugs use a syringe service program. So that can mean that the percentage of Powell County residents could be as high as 8% of people that inject drugs. And so you look at these counties: Powell, Clay, Owsley, McCreary, Lee, Knox, Magoffin, Wolfe County, Perry County, and Carter County. Many of these are those vulnerable counties that were identified by the CDC in that early study in 2014, 2015. So even though we're 9 years past that study, we still have communities among us that have very high percentages of a population that inject drugs that need our services, all of our services. They need HIV and hepatitis C testing. They need substance use treatment. They need Narcan. They need all the services that we're offering in partnership together. So I think it's just an important piece of information to know that we do have a significant percentage of our communities that inject drugs that need our services. Next slide, please. So just to kind of give you a little bit of data about our program, and then I'll throw it back over to Chase. So in 2021, when we were first making our transition, you see our HIV testing through outreach, and it is primarily focused in the central and southeastern part of the state and in the far western part of the state. But in 2022, we have tried to make a much more regional approach. Our goal is to test in every county in Kentucky at least once a year. The opportunities are different in each county, and so in some counties, we're there every week. In other counties, we're only there once a quarter or once a year for different activities that are available in that county. But we are trying to expand our reach and our partnership with organizations throughout our communities in Kentucky. Next slide, please. When you look at our, let's see, is this the next slide or is the map the next slide? John, sorry. Okay. Sorry. Okay, so when you look at, we test in 3 different types of scenarios. One is in partnership with the syringe service programs. One is through walk-in testing at the local health department level. So those are advertised hours where people who are at risk know that they can come in and get an HIV test and education. And then we also do that through targeted outreach. These percentages have aligned a little more than they had in the past, but SSP positivity rate has been the highest for our program, continues to be the highest for our program, but walk-in testing is kind of a dark horse and one that we've really started to focus on to make sure that in every county we're in, that we have some hours where a person who is at risk for HIV can come in and get an HIV test. Those are typically outside of syringe service program hours, but some health departments advertise them, so that both services are available. A person can come in and access syringe service program services, or they can just get an HIV or hepatitis C test if they're at risk. But that service is so important because you do have a population that knows that they're at risk and needs that opportunity to come in and get a test and know their status. And then through targeted outreach, of course, the percentage is lower. I will say, because our focus is on targeted testing. We have a screening tool that we implement in targeted outreach. So not everyone that comes and presents to us during an outreach event will actually be tested for HIV. We'll do a screening tool with them. We'll talk about risk factors, and if the person's not at risk, we're going to provide them education, but we're not going to test them because that's how our funding source is set up, that we're only supposed to test people who are at high risk for HIV. But if the person, is high risk for HIV, we will test them and provide education and supplies. I will tell you that about 20% in urban areas we don't test. So we test about 80% in urban areas, and it's actually a higher percentage in rural areas that are at high risk for HIV, and we're able to test based on those screening tools. Next slide, please. And this slide just represents our positive tests. So this is from 2022, and I will tell you that 2023 is going to look a little different, that we have had an increasing number of positive tests in both eastern Kentucky and in western Kentucky that aren't as reflective here. The first couple of years, Jefferson County, Fayette County, northern Kentucky were our hot spots, as you would expect. But as testing is getting more prevalent throughout our communities, we are seeing increases in the southeastern part of the state and the western part of the state. But for 2022, these were our positive. The red dot represents the positive tests within those communities. So hepatitis C, our funding really follows HIV, and we have had to creatively put together funding sources in order to continue hepatitis C testing. So through CDC, ending the HIV epidemic funds, a partnership with the Kentucky Department for Public Health, and through Gilead Focus Funds, we have been able to relaunch effective August 2022 hepatitis C testing. And when you look at our numbers, you see why we needed to. Our positivity rate in the syringe service programs is about 34%. In outreach, it's 17%. In walk-in testing, it's 11%. So overall, it's about 24% of the people that we test for hepatitis C are positive. That really only tells us that they have antibodies for hepatitis C, and so there's work that has to follow that initial test, confirmatory testing, and then linkage to care. But when we had to stop this service for a time period, we knew that we had to find a way to get it back up and running because, as our data shows, Kentucky is 7th in acute hepatitis C infections. And so being in the communities that we are through the syringe service program, through outreach, we're in communities that are at high risk for hepatitis C, and we have a cure, and we need to get them connected to that cure. So that starts with testing, and then we need to get the person connected to medical services to cure their hepatitis C. And so you see the hepatitis C positivity rate is everywhere, particularly in central and eastern Kentucky. HIV is still pretty centered in our urban areas of the state, but hepatitis C is everywhere. And so we've really been trying to expand hepatitis C to those at-risk communities to identify providers throughout the state that have gone through the camp trainings who can provide hepatitis C treatment and getting our participants connected to hepatitis C treatment. We're also partnering with the viral hepatitis branch to integrate hepatitis C testing and treatment at some of the syringe service programs. So WEDCO has started, they had a nurse practitioner that was already providing hepatitis C testing, but through viral hepatitis funds, we've been able to provide some transportation assistance and some incentives for treatment milestones, and hoping to engage syringe service program participants that test positive for hepatitis C into treatment on site. And that has been very successful. We're now working with the Lake Cumberland District Health Department to launch telehealth services. So the participants through the syringe service program that test positive for hepatitis C will be hopefully engaged in telehealth services in a partnership with the University of Kentucky to receive hepatitis C treatment through telehealth at the Lake Cumberland District Health Department. So as we're able to cobble together funding sources for these different programs, we're hoping to expand this model because preliminarily it looks like it's really successful in getting participants engaged in treatment. Next slide, please. Okay, so just kind of as we round out in terms of health education and risk reduction, in 2022, we were able to interact with 90,000 at-risk members throughout our community. 66,000 of those encounters were through syringe service program, and an additional 24,000 were through outreach activities throughout our community. So mobile units have been great. The health departments that have been kind enough to share their mobile units with us have really allowed us to get into other areas of our communities to provide services where there is a lot of transportation and physical barriers for participants to get to us. And so that we have really appreciated that partnership at the local health department level. Next slide, please. I think that's it for me. Pass it back over to you, Chase.
Thanks, Jana. So really now to close out our content for our presentation, just wanted to go and do some myth busting. So I think that John has some polls, and we have 4 different true or false questions that we want to gauge from the audience. So our first one is, if SSPs reduce the spread of infections like HIV and viral hepatitis.
Please ignore the question, are you worried about stimulant use in your community? I edited a poll and I did a poor job, so I apologize. Got about half, but I'm going to go ahead and end this poll and share the results.
All right, so it looks like all of our respondents were 100% for true. So that is correct. SSPs do reduce the spread of infections such as HIV and viral hepatitis. And in particular, higher syringe coverage is associated with lower odds of HIV risk and does not increase unsafe syringe disposal among syringe service program clients. So we're definitely, for each of these, going to provide you with additional literature that is peer reviewed for your reference for each of these points. We'll move on to the next one. So our next one, SSPs encourage drug use and increase the frequency of drug use among current users.
All right, we got about 70%.
Okay, so it looks like we have 33% saying that that is true, and 67 feel that is false. So SSPs do not encourage drug use, and they decrease the frequency of drug use among current users. And for, of course, reference, we are providing additional literature that supports that.
Oops.
Our third one. New users of SSPs are 5 times more likely to enter drug treatment than those who don't use a program, and are 3 times more likely reported to stop or reduce their injection drug use. True or false?
So again, apologize for the poll that it says stimulant use. We're just using the true false. So I edited the poll, but I will try and fix it for the last one.
Okay, it looks like 96% feel that that is true, and 4% false. So this is actually true. So there is literature from a research study with exchange participation in Seattle drug injectors that it proved that there was a reduced injection frequency and increased entry and retention in drug treatment that were associated with SSP participation. And then we got one more. Our last one. Do SSPs increase risk of needle sticks for first responders and the public?
All right, we got about 70%.
Okay, thank you. So it's like 24% are saying that this is true, that they do increase risk for needle sticks, with 76 feel that it is false. So this is false. SSPs actually decrease the risk of needle sticks for first responders and the general public. So there's been an extensive amount of research that does conclude that there is a reduction in this and not an increase. The one that we have on here is a published article of the comparison of syringe disposal practices among injection drug users in a city with versus a city without a needle syringe service program, and it shows that decrease of having an SSP established in a community. And I will also make a reference that in the Senate bill that gave approval for Kentucky to operate syringe service programs, it stated that participants are encouraged to disclose their syringe possession to receive protection of their paraphernalia, therefore that this will reduce sticks during a law enforcement search as well. Now,
Right.
all the content that we have for today.
That is correct. So first, I would like to thank our speakers for their presentation today, but we actually have a little bit of time for questions. So at this point, I would like to open it up and see if anyone has a question. I did get one question, and so this was from, well, I got a couple questions, but this one was regarding on one of the slides, and it was talking about toxicology of what was found in overdose deaths, and one of them was 4-ANPP, and I personally don't know what that is, but someone else didn't. So
that is an analog that is associated with fentanyl, but for some reason it's pulling them separate in a toxicology report.
got it. So it's essentially fentanyl.
Yes, a derivative of it.
And then Chris put all those publications from the myth busting in the chat. So if anyone's interested in looking at those are there as well. So at this time, if anyone would like to come off mute or raise their hand, please feel free to do so.
Thank you so much for this really great presentation, the both of you. When we're working with clients out in the community and knowing that there's all these resources there, what would you suggest for the best way to advise people to get some of those services for like screening, knowing that it's the targeted screening if we're looking at HIV and hepatitis C?
Are you asking specifically about testing, like how they could access testing in the community?
Yes, please.
Yeah. You know, I feel like the local health departments is the best place to start. All of them offer HIV testing. Some of them offer it just through the clinical services. Some of it offered through our partnerships. So I think the local health departments are the best place to start. Our program maintains an outreach calendar that is separated by region and county. So I will put that in the chat box so that you'll have access to our website and the calendar where we provide HIV testing, walk-in testing, or outreach testing, and you could refer people to that website as well. Also, the Kentucky Department for Public Health, on their website, they have locations that offer HIV testing regularly through community-based organizations like AVOL in Lexington or VOA in Louisville. So there are a lot of resources that are available for testing, and I'll throw a couple of those in the chat.
So from the chat, I wasn't aware of an HIV outbreak in Jefferson County. I'm curious to hear more about it and some of the driving factors, especially as we work there in Wave 2 for the Healing Community Study.
Chase, do you want to answer that, or do you want me to?
Go ahead if you want to.
Okay. I know we've both been on the calls, so I didn't want to jump on you. So the Jefferson County outbreak, we noticed as a team that we were seeing increasing positive tests through our syringe service program testing and through outreach efforts. And so whenever we see that, we send an email to the Kentucky Department for Public Health and say, you know, we're seeing a lot of positive tests, or what we feel like is a lot of positive tests. Are you seeing this in other locations? And between our program and between testing that was happening through Louisville Metro and through the emergency rooms there and through the 550 program, all of us were kind of seeing an increase simultaneously. And so Manny Singh and the Kentucky Department for Public Health started regular calls with everyone that was kind of working in the space so that we could meet together and make sure that we are testing in the right places and not duplicating each other, but really kind of working collaboratively to provide testing. The CDC molecular testing that they do that kind of identifies connected cases and outbreak work. You know, that happened at the Kentucky Department for Public Health level. And so at these meetings, Manny would provide education about, you know, what they were seeing from a CDC data side of things. And then each person would kind of present what they were seeing on the ground and things like that. So I think we are moving out of the outbreak, is my understanding from the last couple meetings. It was primarily in the injection drug use community at first, but in the last meeting, Manny mentioned increased positive tests in populations over 50 and in the Hispanic population. And so I think all of us are kind of directing our efforts there because they're seeing an increased number of people that are positive coming from those communities. And so we're really kind of focused on those populations now. But if you want to put your email in the chat, I'm happy to pass that along to Manny, because he's, you know, if he finds people that need to be involved in the discussion, he's adding them to the discussion. So I'm happy to pass that along to Manny.
Then I had a question. So when I lived in Georgia, I was able to get trained as an HIV tester volunteer. And then for some events, I was put on like a listserv. And when they needed people for events, you know, they would send out kind of like a thing. Is that a thing that happens here in Kentucky, or is it all like professional HIV testers, I guess?
That's a great question. So there is a testing training that's available through the Kentucky Department for Public Health. It actually just went through a pretty significant change based on some changes in CDC guidelines. So it's called testing in non-clinical, I'm drawing a blank on what the new name is. But it requires a couple of online courses through train.org and then an in-person training. But it is designed for non-clinical people to provide the rapid test. And so it provides the counseling, the education, how to perform the test, how to do the controls, all of that kind of information. So that is available for just regular people like us.